everybody. We are going to talk about gait deviations and compensations now. So this video is for you to look at as you're studying, and I will use it during lecture as well. So as we go through each one that I'm going to perform with your handout, you'll understand more comprehensively with the motions that are involved. So starting in your handout, in your gait lecture handout, we're going to start at the top with weakness or hypertonic or flaccid dorsiflexors. So looking at the muscles, if it says dorsiflexors and they're weak, whether it says hypertonic or flaccid, all the same thing, that mindset is they're too weak, whatever muscle we're talking about, to hold against gravity the joint structure, okay, so what's distal to it. So the first is the ankle. We're starting with the ankle, and looking at stance phase on the left side of the paper and swing phase on the left side of your paper, and then looking at the right and seeing what the deviation or compensation is, and knowing which is a deviation or which is a compensation. Know that deviation is the problem. Compensation is something that the patient does to fix the problem, but we'll talk more about that in lecture. So if I had weak, or flaccid or hypertonic dorsiflexors, what would happen? So on the right it says initial contact with toes. So looking at my feet, okay, as I walk, and if my right is affected, and that's the weak side, as I go ahead and do a step, my heel strike doesn't happen, my toes hit first. So looking at the right, my heel strike is not happening, my toes are hitting first because, and I'll go this way, because I don't have dorsiflexors holding against gravity, okay? So in the swing phase, you'll see that they drop, and then my initial contact is with the toes, not the heel. So that's initial contact with the toes. The next, the weakness in the dorsiflexors, I have foot slap. So now, as I walk, my foot is slapping. I have less control on the right, again, is affected. So I'm slapping that foot instead of softly, gently allowing my toes to contact first or allowing the heel. Okay, same reason. Foot flat is the next one. Have a little more control, but my dorsiflexors are weak. So now I'm placing my foot flat, not my toes or my heel. It's both together, foot flat. So let me go this way. So I'm still weak dorsiflexors, but my foot is hitting flat. Okay? The next, now we're talking about swing phase compensations that allow the swing through so that I don't hit my toes or drag my toes on the ground. But the first one is foot drop. So this is what happens as we swing through. Okay, so we just talked about stance phase, now we're swinging. So swing through is this on the right, okay? I need dorsiflexion, I need knee flexion, and I need hip flexion. Degrees of each, and we'll see it's 60 degrees here, 30 degrees here, an ankle at neutral, so I could clear and not trip over my toes. So when we have dorsiflexors that are weak or anything that create a longer lower extremity, we cannot clear and swing safely. So foot drop or dragging is going to be similar to this. So when you say drop, this is what's happening to the patient if they don't do anything about it. They're just dragging or dropping that foot, and then potentially can fall. So that's why they'll compensate to swing through safely. And the next are compensations. So steppage gait. So now I'm going to use my hip and knee to overcompensate for that foot to not touch the floor during swing. So now I'm going, extra excessive knee flexion and extension, knee flexion and hip flexion. This is steppage gait. Okay, so making sure, okay, my weak dorsiflexors, okay, I can clear by, doing excessive hip and knee flexion, that's steppage. The next one, in order to clear my toes, again, would be circumduction. So now at the hip, you'll see as I try to swing through the affected leg of weak dorsiflexors, I'm going to do this. I'm swinging, but I'm doing this circumduction effect where it's allowing the length of my leg to clear. So that is circumduction, okay? The next one is hip hiking, another compensation to afford me the space and room for the swing phase to happen. It's going to happen up here. My quadratus is going to kick in, and I'm going to hike my pelvis up to swing through to allow for that extra length. So I'm doing it again. Hike, hike, right here. So my pelvis is lifting, okay? The next one is vaulting. This is a little more complicated. It happens on the contralateral side. So now I'm going to use my contralateral plantar flexors to lift my body so that I can clear the affected right side. That foot is still dropping. I have weak dorsiflexors. To clear that foot, I want to raise my entire body to swing through. This is vaulting. So you see how I lift? So go back again. Lift so I can swing through that affected right side. Okay? So the next on your list says weakness, hypotonic, or flaccid plantar flexors. So you know that it's heel off, okay? Heel off, looking at my right. That part of gait is not going to happen because I have weak plantar flexors. So I can't plantar flex, okay? So that initial swing, that last phase of stance where it's heel off, toe off is going to be affected. So as I'm going to do this laterally for your view, is that as I lift, I can't do it the heel off, toe off, no plantar flexors, then I'm going to lift and advance the lower extremity just like so. So kind of like a flat, I'll walk this way. So again, the right side. So I'm just going to step, kind of looks, can't do it without other compensation. It's going to shorten my step length a bit, but I'm going to advance it without the heel toe off. So you'll see I'm heel toe off on the left, no compensation here, but the right side, I have no heel toe off, okay, because of those plantar flexors not allowing it. So that's calcaneus gait. Calcaneus gait. Okay, so the next one is hypertonic plantar flexors. If I have bilateral plantar flexors, spastic, hypertonic, what's it going to do? Put me in plantar flexion. So look at my toes, okay? I'm on my toes. I have hypertonicity in my gastroaxillary complex. I can't put my heels down. So I'm constantly walking like this. This is an equinus gait. So if it's bilateral, okay, I have an equinus. I just walk on my tiptoes. You know what pathology this belongs to. If you don't, we'll talk about it, okay? So that's our equinus. If I had only one side that was hypertonic plantar flexors, then I would still be creating this longer lower extremity and can't do swing phase. So now what do I have to do? Well, I can circumduct, as I did before, or I could hip hike to clear, or I could do steppage gait to clear. So again, if I'm stuck in plantar flexion, I still have to clear because it's longer lower extremity. Okay? All right, so let's keep going. Okay, so now we're at the knee, and if we had weak hypotonic flaccid quadriceps, what's going to happen? Well, stance phase, I need them. I need to lock out my knee joint in stance phase. So that's going to be the problem. So we have what's called genu recurvatum. So as you see laterally, if I just take a step and I load on this leg, if I don't lock my knee out, I'm going to buckle, okay? So one of the compensations to do that locking out of the knee is for a patient, when they load, to slap back that knee in extension so that they ensure that they're stable. So it's locking out, locking out, locking out, slapping back. This is genu recurvatum gait. Slap, slap, slap. So you see the load slap, okay? Okay, if I didn't do that, I didn't have that compensation happen, what's going to happen? Knee buckling. I go to load in stance phase, and my knee gives way, I'm going to buckle, I'm going to fall if I don't do something about it. This is one of those times where that patient needs a gait aid, okay? So I'm buckling. So I step, I load, and I buckle. I could fall. Again, step, I load, and I buckle. And a lot of people just catch themselves from falling if they're not using a walker or a cane. So that's knee buckling, deviation. All right, the last one for knee, for weak quads, is our forward trunk lean. Our forward trunk lean, as I load, again, I don't have those extensors to lock out the knee, I'm going to forward flex, mechanically lock out my knee using the tension in my hamstrings, creating that pelvis to go anterior and pull on those hamstrings. So it's kind of like a duck walk. So again, the right one is affected. Every time I load, I'm going to lean. I'm going to load and lean. Lean. So it locks out my knee mechanically. Okay, so that's the forward trunk lean. Okay? All right, so the next says, we're talking about swing phase, okay, of gait here. And we're talking about weak, hypertonic, or flaccid hamstrings now. Hamstrings. So we know that when we have swing through phase, we need knee flexion to be at least 60 degrees. See how I swing okay? If I don't have that swing phase clearing with 60 degrees of knee flexion, I'm going to drag my toes because that's the one closest to the floor. So I need enough knee flexion, but if my hamstrings are too weak, okay, I'm going to get that toe drag. So the things I can do to compensate because I don't have my hamstring strength is still the circumduction, okay, so again, right side affected, or I can do hiking. Hiking will work again. So same compensations that we did with the ankle for ankle weakness, we're doing now for the knee weakness flexors, because that's what we need in swing phase. The other one is vaulting. So using the contralateral side to lift my whole body up. Again, I'm lifting. It's not for the ankle this time, it's for the knee flexors. The last one says excessive hip flexion. So we can't use steppage gait here because steppage gait by definition was excessive hip and excessive knee flexion. So we have to do just excessive hip flexion. So when I swing through, I'm doing excessive hip flexion to swing that body or that lower extremity through. Okay? Again, we don't have hamstrings, so I can't do excessive knee flexion. So excessive hip only. Okay, the next one says weak, hypotonic, or flaccid hip flexors. We know that along with the knee flexion of 60 degrees, we need 30 degrees of the hip flexion to help us to clear that foot. So if we don't have the hip flexor strength, okay, then I'm going to have the same result. I'm going to have toe drag because I don't have enough hip to lift my leg to advance it during swing. So the same resulting factors for our compensations, I can do my same compensation. So which one was that one? Circumduction, okay? Which one is this one? Hiking, okay? So, and then the last one you could use is the vaulting, okay? So vaulting, and we can't use that excessive hip flexion or steppage because I don't have the hip flexors. They're weak, and that's the reason why I'm doing the compensation to swing through. Okay, the other last one, oh, not last one, getting to the last one, is weak hypotonic flaccid hip extensors. So think of glutes. If I don't have enough glute strength to lock out my hip in stance phase, I've got to do something about it. So, and we all know glute max gait because I lean back, resting on the wide ligaments. You guys have heard this before. So if I lean my thorax back, I put my hip into extension. So now I'm safe because if I walk with my thorax back and my hips in extension, I'm not going to buckle here. Okay, so again, thorax posterior, mechanically locking out the hips. I can rest on my wide ligaments. All right, very useful for spinal cord injury to gait, to do gait. All right, let me see. Next. Okay, so weak hypotonic or flaccid hip abductors. We know that this is Trendelenburg gait. We've talked about this. And you know if I have a weakness in a glute medius muscle, we're talking about lateral tilting. If I have a weakness on my right side that's affected, so I have a weakness here, as I load, okay, this muscle here should contract enough as I lift up the left leg not to allow that pelvis to drop, okay? So I should be able to be level pelvis if I lift up the opposite leg. if I don't have the strength in my abductors on the stance side, so this is my right stance, as I lift up, I'm going to drop the pelvis. I'm trying to compensate here, and I'm going to trunk lean to the side that's weak to compensate to stay up. So there's twofold thing happening here with Trendelenburg gait. I step, my weak hip abductors don't hold my pelvis, it drops on the opposite side. I lean to the side that's weak, and I look like this. I'm going to do it this way. Okay, so you know when somebody walks into you right away, your clinical eye should say, Trendelenburg gait, because you could see the side they lean to. The side they lean to is the weak side, so they can stay up, because as soon as that leg lifts, it's dropping and pulling them down. So that's Trendelenburg gait. Okay, your other listed abnormality gait patterns, or abnormal gait patterns, is your antalgic gait. So if somebody's in pain, antalgia, say it's the right ankle, they're going to hurry up off that side, so it's going to look like this. And an ow, you know, I'm going to go, ooh, ooh, because when you look at a patient trying to ambulate on a side that is hurting, they're going to hurry up, get the weight of it off so that they can spend more time stance phase on the unaffected side. So that's antalgic gait, anything painful in the lower extremity. Ataxic, we know it's a wide base of support, it's staggering, goes with pathology, where is the lesion. And then our tabetic was the ataxia, but kind of adding the audible slap. So I don't know where my foot is in space. I have a DCML lesion, and I'm staggering and I'm stomping because I don't know where my foot is in relationship to the floor, okay? That's the difference between ataxia and tabetic. They're kind of staggering, and they're wide base of support, but yet we've got the audible slap for the tabetic gait. Parkinsonian gait, we know it's that shuffle, okay? I'll do it this way. It's where I have my tremors, my pill rolling, my forward flexed posture, and we have small step length, and we're shuffling, and we're slow, bradykinesia is happening, okay? They don't turn very sharply, very quickly, nothing's quick, okay? So this is, and if it's a fascinating gait, then their feet are going to try to catch up with their forward propulsed flex posture, and they're going to look something like this, okay? So that's your Parkinsonian gait. Your hemiplegic gait is, think of hemiplegia, one side is affected, okay? So if I have right side affected, okay, I have a left CVA, right side affected, hemiplegic, this whole side, plegic. So basically, and I have my typical tone pattern here and here, extensor and flexor tone on the one side. Basically, my left side's doing all the work. So I'm kind of dragging the side that's plegic, okay? Probably I'm using a hemiplegic walker on this side, but my pelvis is retracted on the right side, as you saw, okay? So I'm dragging it, okay, along, just like this. So that's hemiplegia gait. And the last one is scissor gait, okay? So I have spastic adductors, and basically if they're pulling in while I'm walking, it's going to look like this, okay? And that also sometimes goes with your equinus. So equinus and scissors, I can be up on my toes, and I can be fighting that adduction, but that scissoring gait. So you see the scissor effect of the lower extremities crossing over each other or meeting each other. And that is it. Thank you.